Our next speaker is Dr. Lindsay Elliott. She is a pediatric psychologist. She got her PhD from the University of Alabama at Birmingham. She trained at Nationwide Children's in Columbus for her internship. We overlapped there, but we didn't actually know each other then. And then she came to Austin for her fellowship, which is where we connected for the Psychogenic Non-Epileptic Events Clinic. But she is also coming over to neurology full-time to work with both our functional patients as well as our headache patients. So we're really excited to have her on board.
Okay. So I have no disclosures to provide. I'm hoping today that you all are able to walk away with these three things, so being able to understand what the psychosocial risks are for pediatric patients who have neurological conditions, identify which of your patients may be at risk for those risks, those psychosocial challenges, and then evaluate the quality of psychotherapy that you're either referring to or that your patients are already receiving. We know that individuals and children and adolescents in particular who have neurological conditions, and I use that term really broadly, right? So that includes headaches, that includes epilepsy, that includes neuromuscular disorders, so it's really broad. But we know they're at increased risk for a number of different things. They are certainly at an increased risk for formal diagnoses of mental health concerns, so things like anxiety and depression most commonly, but they're also at risk for just kind of elevated symptoms of anxiety and elevated symptoms of depression, even if they don't meet for a formal diagnosis. We know that they are at risk for behavioral challenges, so that includes acting out at home, increased irritability. Some of that we think is due to the way those brains develop, but also some of that can be medication related. And so these patients might be having those challenges both at home and at school. We know they're also at risk for developing learning difficulties. So that can be having intellectual disabilities, but that can also include specific learning disabilities, difficulties with attention, concentration, and focus. That can include things like sleep disruption that then leads to challenges within the academic setting. So there's a lot of risks within this population in school. And then in general, we know that these patients report having a lower quality of life compared to their peers who do not have a medical condition. And so lower quality of life is really a broad term. We're talking about home life, social life, school life, but we do know that they tend to report experiencing that lower quality of life. So when do all of those concerns reach a level that we think we probably need to refer to therapy? I think first and foremost, if they formally meet criteria for a diagnosis like anxiety and depression, there is a lot of evidence that supports that therapy is a very good first line of treatment for this population. Ways that you can look at that in your general clinical practice would be through screeners. The most common ones would be the GAD-7, looking at generalized anxiety disorder, or the PHQ-9, which is looking at major depression. These screeners can also just kind of give you an idea of even if they're not meeting formal criteria, like are there areas that are elevated that may warrant some treatment? The second thing that I look at outside of do they meet criteria for a diagnosis is how impaired is their functioning. So even if you have a patient who maybe doesn't meet for a formal diagnosis, if we are noticing significant impairment across multiple domains of their life, they may still benefit from therapy. So that might include things like limited school attendance. So in particular, if we see that they're having a really hard time going to school with regularity, are they leaving school early frequently? Is that leading to challenges either socially at school or with their academic performance? That could be a good indication that they might benefit from some therapy techniques to improve their ability to engage in their life and again, hopefully reduce that impact on their quality of life. If you're seeing a significant disruption to their social functioning, so this is more along the lines of maybe they were doing really great socially for a long time, and all of a sudden we're seeing a lot more social withdrawal or difficulty making friends, or maybe they have always struggled with peer relationships, but they're starting to notice that impact. that might be a good time to consider therapy. And then the last piece I would consider would be disruption to family dynamics. And so if the family is coming to you and reporting, like, yes, they don't meet criteria for a diagnosis, but we are really concerned because our child's not sleeping, or we're noticing significant withdrawal, or they're really irritable, and that's really hard for the family to manage, that could be a good time to consider a referral to therapy. One way that you all could measure that is through the PEDS-QL. This is a quality of life measure. This is not quite like the GAD-7 or the PHQ-9 that's looking at diagnostic criteria. There are no diagnostic criteria for quality of life, but that can kind of provide you with an overall kind of measurement of various components of quality of life to kind of see where they might be impaired. Once we decide they need to be referred to therapy, I think it's always helpful to think about who we're referring to. This in particular, I think, comes up a lot with patients and families who maybe don't have as much familiarity with what the various types of mental health services are that they can receive. So all three of these types of providers are able to provide therapy. And so helping patients and families understand the differences, and then also knowing when you might refer to one versus another. Psychiatrists, I think that's the one that's easiest to kind of pull apart. They're obviously the ones that can prescribe medication. Psychologists and therapists cannot. But psychiatrists can also provide therapy. What I always think about if patients are getting their therapy from a psychiatrist are kind of twofold. One is, how often are they getting that therapy? So often psychiatrists do not see their patients with the same regularity that a psychologist or a therapist might. And so really thinking about, are they getting kind of the right dosing of therapy if they're seeing a psychiatrist? And the second piece is cost. Of all of these providers, psychiatrists are the most expensive. And so just thinking about if that's something that's sustainable for your patients. The nuances and differences between a psychologist and a therapist are a little bit harder to piece apart. A therapist is kind of a broad term. That can include licensed professional counselors, masters of social workers, LCSWs. It's kind of a really broad term. The main difference between a psychologist and a therapist is training. So a psychologist has more training than a therapist does, and often a psychologist will have more specialization than a therapist does. So therapists tend to treat kind of a wide variety of things, whereas psychologists are a little more specific in what they treat. So why would you send to one versus the other? Psychologists, I would say, you're sending them when you think the concern is very specific and they might not get that need met in the broad community. So that could look like pain disorders would probably benefit from a psychologist who has training specific in pain. Functional disorders, they may benefit from a psychologist who has specific training in functional disorders. Or even things like if we think there's significant concern for like insomnia, psychologists are more likely to have that specific training. The only caveat I'll give to that is that psychologists are hard to come by. And so therapists, even though mental health in general is hard to come by, therapists are more likely to be readily available to have open appointments for new patients, and also to be more available to your patients who live in maybe more rural areas. So psychologists tend to be housed with academic medical centers. Not always, we're also in private practice, but that's also much more expensive than a therapist. So that's the one caveat I give to that, is that often therapists may be more available. Common types of therapy, so these are what I would consider to be evidence-based interventions. So this is what the research has shown us works for these different presentations. So the buzzwords that you're looking for, and I'm not going to go into the details of what each of these treatments are, but you want to look for mood and anxiety, you're looking for things like CBT, DBT, interpersonal therapy, or for anxiety, exposure and response prevention. For those behavioral challenges, you're looking for something like parent-child interaction therapy or parent management training. Those are kind of the buzzwords that you want to see. For all of these types of therapy, there are what I consider to be critical components of any type of therapy. So the first is that it should have goals. Goals are gonna look different depending on what the patient's presentation is, and they should have input from both the patient and from the parents. So goals may look something like increased school attendance, or it could be around like behavioral activation, so spending more time with friends. They should be very specific goals. It's not just kind of this nebulous, like, we should feel better. Goals are really meant to be specific in therapy. Therapy should also be active. This one I think is always kind of confusing to families because we have this like stereotypical idea of what therapy is, which is I go and I sit on a couch and I talk about my day. But therapy really should be active. We should be building skills. We should be taking homework home and learning how to integrate those skills into our daily lives. And then this last piece is that parents should be involved. This gets a little bit stickier when we're talking about our teenagers, and this is not to say that parents should be in every single therapy session for the duration of it. However, we know that kids don't live in a bubble, right? They live in a unit, and they need to be supported in the changes that they're making. And so this will vary by age and by presentation. So I would expect that patients who have behavioral challenges, that parents would be much more involved, and that parents would actually, so for both PCIT and parent management training, parents are actually the primary people who are receiving therapy. As our children get older, we're getting in more to like adolescence, it's not that parents stop being involved, but they may be less involved. So parents should still be aware of what their children are working on in therapy and how they can support in the home. And so parents should always be a part of the therapy approach. I want to talk about some, I'll call them yellow flags. They're not quite red flags, but these are things that when I am talking to or consulting with a family in the hospital and I'm assessing kind of the quality of the therapy that they're getting, if I hear kind of some of these things, these are things that I maybe want to assess a little bit further and see if the family's getting the right type of treatment. The first is neurofeedback, and I want to separate this from biofeedback. So neurofeedback, the reason I put this on here is twofold. One, there's not a lot of evidence yet that it's very effective in treating anything from a mental health perspective. And the second is it's often not covered by insurance, so it's very, very expensive for families. So I'm always hesitant when that is something that families are pursuing. That is separate from biofeedback, which has a lot of evidence for both anxiety and pain. The second, and these next two kind of play therapy and EMDR go hand in hand. So both play therapy and EMDR do have evidence for treatment. However, they have very specific evidence. So they are both evidence-based in trauma and not for a whole lot else. So if you have patients who have experienced trauma, they can be a good choice for treatment, but I do get a little bit more worried when EMDR is a first-line treatment for other types of mental health concerns, especially because there are lots of other really, really good therapies that have much stronger evidence. The next thing that I get cautious about are therapists who have a broad array of specialties that they claim they're good at. So if you're looking on like Psychology Today and you see that a provider has listed that they treat patients all the way from age 2 up until 60, that's usually a pretty big red flag for me. Similarly, if they list like 30 different things that they're able to provide, that's concerning for me. It's concerning because I think we all know like we can only have so many specialties. We can only keep up with the literature in so many different areas. And so if a therapist is saying they have all of these things that they're really, really good at treating, I'm a little bit hesitant and a little bit worried about that. The last piece that I am always worried about is if they're in prolonged therapy and they're not having progress. So these are the patients who are saying, I've been going to therapy for 6 months or more, and nothing's changed, nothing's getting better. I caveat this a little bit because this might look different with parents' perspective and the kid's perspective. And so I think it's important to kind of get input from both. So the kid may feel like things aren't helping, but if the parent's telling you, actually they're more engaged at home, they're less irritable, I'm noticing changes, that might not mean that therapy's not working. But if both the parent and the kid tell you like, yeah, we've been in therapy for a really long time, and nothing's getting better, that might be an indication that maybe that therapist is not a good fit. All of this to say, there is also a lot of research that shows that regardless of modality of treatment, so whether it's CBT, DBT, PCIT, or one of these types of treatment, there is some evidence to show that the relationship between the patient and the therapist can be a bigger indicator of success in treatment than the modality itself. So even if your patient's getting all of these things, if they say it's helping and I have a really good relationship with that therapist, we don't necessarily have to say, okay, well then stop seeing them. I want to end with some practical questions, so things that you all can actually use in your practice. These are things that I often ask patients and families during my consultations with them. So the first question I ask is, how often do you see your therapist? This goes back to what I was mentioning earlier about often with psychiatrists, they're not seeing them with regularity. I would want patients to, at least initially, be being seen at least every other week, if not every week. Sometimes they will move into what we would call like the maintenance phase. So if they've been in therapy for a while and things are improving, that might be happening with less frequency. But I do want to assess, at least early on, how often they're being seen. The second is I ask kind of broadly and open-endedly, like, what does a typical session look like? This has some nuance to it because sometimes teens and children are really bad at telling you what happens in therapy, right? And so I think hearing from families too can be helpful about that. So sometimes kids will tell me, I don't know, I just go in and talk. And then you might have to ask some more nuanced questions about what's happening. So that might look like things like, well, is mom there? Do you get homework? Sometimes kids will tell you, I go in and I play the whole time. And that's usually a little yellow flag for me too, of like, okay, well, are they actually learning things in therapy? And that's when I move into this next question of, well, what skills have you learned? And so having them be able to concretely tell you what they've learned, what they've been able to change since they've been in therapy. You're looking for things like relaxation skills. So maybe I've learned mindfulness or breathing skills or progressive muscle relaxation. Or they might also talk about cognitive strategies. I've learned how to change my thoughts, or I've learned how to accept some thoughts and move past them. So you really want to hear that they have concrete things that they've taken away from therapy. And then I like to broadly ask, do you feel like it's helping, right? So if you ask that and they're like, nope, okay, well then we need to find someone new, right? So I think being able to ask directly if they feel like what they're doing is worthwhile. And then I'll also ask parents specifically, how often are you included and how are you included? So are parents learning what their kids are learning so that they can also implement those skills, or are parents just not present at all? We want to know how we can help support parents to be able to support their kids. That's a really, really critical part of therapy. Okay, questions?
What is the number of sessions required before you get any appreciable benefit? You mentioned about, 6 months or something, but
Yeah.
Is there any specific months or number of sessions it requires?
That really depends on the modality. So the question was how many sessions before we start to see benefit. I think that depends on a couple of different things. So I would say first it depends on the modality itself. So some types of treatment require shorter or longer amounts of time. I would also say it depends on the severity of the symptoms as well. Most therapies are going to aim for somewhere between like 8 to 12 sessions, but that can vary quite widely depending on if the symptoms are very severe. We might be making progress after 8 to 12 sessions, but need to continue to really see the full benefit of that. But again, we're thinking about like, are things actually changing during those sessions, right? And things getting gradually better, even if not completely better.
Two questions. First question is, where do you recommend patients find providers? Psychology today seems to be Oh, there we go. Is that better? Oh, there we go. Okay. So 2 questions. Psychology Today, or like what database do you recommend people look for to find a provider?
Yeah, so that's a great question. We have really terrible resources, and Psychology Today doesn't do a great job in terms of like inclusivity for insurances, et cetera. So I think for most patients, the most effective way to figure out who's covered by their insurance would be to start with actually talking to their insurance panels. Psychology Today can be a good resource, and I wouldn't just recommend like, here's a list of all the providers on Psychology Today. We would really want to kind of parse apart, like, these providers seem like they're just taking anybody versus these providers actually seem specialized in pediatrics.
The second question is about telehealth and how that could open up access to people in parts where
That's a
limited
really,
resource
yes.
settings.
So telehealth has definitely opened up a lot. So PsyPact is kind of the psychology version or the psychology tool that passed during COVID that has opened up the ability for many, many states to kind of provide services even outside of your state. So like I'm PsyPact licensed, which means I can serve patients in Texas, but then any state who's passed PsyPact legislation, I can also serve virtually. So that's definitely opened up a lot more options. What that realistically looks like for kids, I think really that's probably provided more options in terms of adults, but just the availability of like pediatric psychologists is unfortunately very limited. Yeah.
That was awesome. Thank you.
Yeah.
Are there any resources that you wish clinical providers would read about how to differentiate different types of therapy and I guess what is expected out of those sessions so that we can kind of follow up as well and ensure that our patients are receiving appropriate therapy?
That's a really, really great question. I don't know off the top of my head if there's any easy like summary articles that kind of take together like, here's CBT outlined and DBT outlined. Maybe we need to create this, Leah. You're creating work for me. I see what you're doing there.
I think I've created 3 or 4 projects throughout the day.
But I do think that would be really helpful of kind of like, what does CBT look like and what would you expect the outcomes for that to be? I don't know off the top of my head what exists, but that's a great question.
How do you motivate or like convince the teenager who is completely resistant to therapy or has had a bad experience or didn't click with their prior therapist, or how do you convince them to try again?
That's a great question. I think, so for that latter part, right, they had a bad experience. I think normalizing that, right, like I tell patients all the time when I meet with them, I'm never going to be offended if you fire me, right? Like I'm not everybody's cup of tea. I know that. I wish I was. That'd be great, right? But I think just normal people, you don't click with every person in your life, so you won't click with every therapist in your life. And so giving them that opportunity of maybe they might meet someone who does click. The other thing I would talk about is there are different types of therapy. So maybe the type of therapy that they had wasn't a good fit for them, but there might be other types of therapy that we can try that would feel better for them. In terms of your teenagers who are just really like, therapy's not for me, therapy's stupid, right? We do hear that. I would just kind of ask about it. Why? Why do you think that, right? And kind of understand where they're coming from and see if you can, one, validate what they're feeling about therapy and then try to move that needle a little bit. And then the other piece is parents. Parents are your inroad, right? So the really beautiful thing about pediatrics is that you have 2 people, right? It's not just the individual who needs treatment that agrees to it, but the parent. And so if the parent has buy-in, then the therapist can also work to get the teens buy-in. I get patients all the time who don't want therapy, and that is part of treatment's early phases, is building that relationship and helping them understand ways that I could be helpful that maybe they hadn't thought about. Yeah.
Did Medicaid Texas pay for this biofeedback?
Does Medicaid pay for biofeedback or neurofeedback?
Neurofeedback.
Does it?
I don't know. I'm asking you.
Neurofeedback typically, I don't think so.
It's private.
Most people who provide neurofeedback tend to be private practitioners, so they don't take any insurances kind of across the board. And then in my experience, I have never had a patient who's gotten neurofeedback that's had it covered by insurance of any type.
So, well, what Medicaid patients are out?
What's that?
Medicaid patients are out of this.
For neurofeedback?
Yes.
Yes. What about biofeedback? Biofeedback is a little bit more nuanced because I don't necessarily bill specific for biofeedback, right? So I think that's where it's a little bit different, and you will find providers who give neurofeedback give biofeedback in the context of other types of treatment. So for example, if I'm providing CBT for pain, I might include biofeedback in that, and I'm still billing under the CBT pieces of that as opposed to biofeedback specifically. Yeah.
Hi, thank you for the great talk. Sometimes the challenge, once you overcome with patient and the family and, they convince them the therapy is beneficial, then they have to wait 6 months to a year to get an appointment. So I'm just wondering if there's anything you recommend in terms of like the referring physicians or the referring practices, anything that we can say in the referral that would like kind of help them get ahead in the line, in a sense, like kind of a triage.
Yeah.
Where like, if it is something that they need to see someone the next month, that they don't have to wait a year to be seen or something like that, especially for new patients.
That's a really good question. I think it really depends on the system, right? So I think if you're referring to like private practices, there are certainly ways that you can kind of emphasize how important it is that they get seen quickly. I would also say if you have patients that they're impaired enough or their symptoms are severe enough that we think like they need to get in ASAP, they may benefit from something like an intensive outpatient program or a partial hospitalization that maybe would be able to get them sooner and kind of get those skills really, really quickly while they're on the wait list for other providers. The other thing that I tell patients is, because one of the barriers we sometimes hear is they say, well, there's a wait list, so I just didn't bother because it was going to take 6 months. And what I tell patients is get on every single wait list that you can. So don't just get on one wait list, get on 10, 15, 20 wait lists if you can. And then what you might see is those wait lists move faster than you maybe anticipate because you have other patients doing the same things, right? And then they might still be on 9 wait lists, but they're already connected, and they just didn't call to go off of those wait lists. But in terms of like the language that you use in the referral, there's not a lot that is going to move that needle. I would say if you really have a patient that you feel like needs it, you're better off probably calling and having that that phone call of like, here's why, and pulling on our empathetic heartstrings.